Hello everyone, welcome to today's class in Medimantra, whereby we will be talking about infertility, approach to how to approach an infertile couple. So this class will be dedicated to infertility. If possible, I'll be taking two classes on infertility. First class will be on the male component of infertility and the second class will be on female component of infertility. Infertility being a very important topic from NEET PG point of view, so we'll be talking it in details. At the very onset, how do you define infertility? So definition of infertility is when a couple is undergoing unprotected intercourse for 1 year unprotected intercourse, still he or she means the couple is not able to conceive, then it is called infertility for a couple. If after marriage the patient has not conceived any time, then it is called primary infertility. Where if she had conceived earlier, be it abortion or a full-term pregnancy, and now she is trying for 1 year and she is not able to conceive, then it is called secondary infertility. So the difference between primary and secondary infertility is this. The other thing which is very important is what is fecundity and fecundability. Fecundability and fecundity. These are two terms which we generally use. Fecundability is the ability to conceive in one cycle, one menstrual cycle. So in one cycle, probably 25% of the couples are able to conceive in one cycle only. This means after marriage, let us suppose a newly married couple has just got married, and after 1 month of unprotected intercourse, how many people will be able to conceive? It is 25%. That is, only 1/4 of the couples are able to conceive in the first cycle. Whereas fecundity means how many percent of the couples are able to give live birth in one cycle. Means out of these 25% couples who really conceive in one cycle, only a few of them go to have live birth, the others end up in having abortions. So it is very important to know how many of the couples really have fecundity. Okay, so fecundity, out of these fecundability, only 25 to 30% will have live birth in one cycle, others will end up in abortion. So this is the data for fecundability and fecundity in one cycle. Now those who are not able to conceive for 1 year, they qualify for infertility. But it is very important to know that if the age of the female is more than 35 years, then we need not to wait for 1 year. In that case, the definition of infertility is 6 months. Means if the female is not able to conceive within 6 months of unprotected intercourse, then we say that it is infertility and we have to start investigating the couple. So less than 35 years, when normally most of the patients come to us in less than 35 years. In that case, 1 year of unprotected intercourse is needed to start investigating them. Otherwise, more than 35 years, only 6 months of unprotected intercourse is required. Now coming to infertility. Out of the total infertility cases, almost 30% of the infertility is because of male factor infertility. Whereas rest of the 40 to 50%, consider 40% as female factor infertility. The rest of it, say 30%, out of this 20% will be combined factor, means both male and female are responsible for this, and 10% will be unexplained. Even after doing all the investigations, you do not know what is the cause of infertility. In this case, we say it is unexplained infertility. Now coming to the female factors. In female factors, basically what are the factors which can lead to female infertility? If we consider this diagram, which we already every time draw and try to explain everything. So the defect can be at the level of the ovaries. So there can be ovulation defect in ovulation, that is ovulation is not taking place. Then there can be tubal block. tubal block. Okay, bilateral fallopian tubes block can be there, and this will lead to the sperms and the ova not traveling from one side to the other. Then there can be uterine factors of infertility, like uterine factors in the form of, it can be maybe a didelphys uterus or a bicornuate uterus which is not allowing for fertilization or implantation, or there can be defect in the endometrium lining is not good, so implantation is not taking place. There can be defect in the outflow tract, okay, or lower down there can be defect, as suppose there is transverse vaginal septum or imperforate hymen. So these can also be the causes of infertility. Apart from that, for ovulation, all the hormones should be normal. It means FSH, LH, okay, these should be normal. These are released from the anterior pituitary. Anterior pituitary is in turn stimulated by GnRH, which is secreted from the hypothalamus. So these all factors should also be right. So these are the causes of female infertility. Now today let us discuss in much detail about the male infertility. We'll consider first the male infertility. If the male infertility is done and we have time today, then we will go towards female infertility. Okay. So in male infertility, always remember how the semen and sperms are produced. So if you consider both the testes, in the testis you have seminiferous tubules. And these seminiferous tubules are helping in formation of the sperms. Now there are two types of cells you all know. One is the Sertoli cells. And the other is the Leydig cells. Sertoli cells and the Leydig cells. So basically Sertoli cells help in formation of the spermatozoa are produced from the Sertoli cells, and Sertoli cells are being stimulated by FSH, follicle stimulating hormone. FSH comes and stimulates the Sertoli cells and they produce the sperms. Also they produce a hormone called anti-Mullerian hormone, okay, or AMH, or the Mullerian inhibiting substance, MIS, Mullerian inhibiting substance, or AMH is produced, which is produced by the Sertoli cells. Secondly, the Leydig cells are being stimulated by the luteinizing hormone from the anterior pituitary, and Leydig cells help in formation of testosterone. Testosterone, we all know, is converted to dihydrotestosterone by the hormone 5-alpha reductase, and dihydrotestosterone helps in formation of external genitalia and the secondary sexual characters like pubic hair, axillary hair, and the beards and mustaches all are formed by the dihydrotestosterone. Now if you consider the male genital tract, what actually happens is there are two testicles, and the testicles will produce the sperms. The sperms will be stored in the epididymis. This is the epididymis where the sperms are stored. After that, with the help of vas deferens, they will be circulated towards the urethra. Okay, they will be circulated towards the urethra. Now before they join and form the ejaculatory duct, before that you will have the seminiferous tubules which will be giving their secretion. Okay, so seminal vesicles. So basically these seminal vesicles, these are glands which will be secreting their secretions just before the vas deferens unites together. After that it forms the ejaculatory duct, and at the base of which you have the prostate gland which will give its secretion, and the bulbourethral glands, and after that it drains into the penile urethra, and the penile urethra brings it to the outside world in the form of the penis. So what actually I wanted to speak is that if you consider the semen, the total semen, then 60% of the seminal volume is added by the glandular secretions. It is the glandular secretions which generally form the major chunk of the seminal volume. And out of these seminal secretions, always remember that the seminal vesicles help in adding fructose, which is energy provider for the sperms. So fructose is being produced by the fluid of the seminal vesicles. This is very very important because we use fructose for testing the level of block. So I'll be telling you in detail how we use the fructose. So this till now this is clear to you all. So basically the entire process of spermatogenesis, we all know it takes around 72 to 75 days. I'm not going into much details of that. You can read it up in your physiology textbooks or the other anatomy textbooks. Okay, but what we will be concentrating is how we generally manage an infertile couple. So basically this is how the semen is formed. Now we have WHO semen parameters, WHO semen parameters which are done. So for any infertile couple who comes to you, husband test is very important because 30% of the contribution will be done by husband. So it may so happen that out of the 100 couples who are coming to you in infertility clinic, 30% will have their husband defect. So get WHO semen parameter or semen test done for all patients. So always remember, these are some of the normal values which you should be remembering. What is the volume of ejaculate? It should be more than 1.5 ml. 1.5 ml is the lowest volume of ejaculate which should be present. Then what is the pH of the pH? What is required is pH should be always more than 7.2. So it is normally between 7.2 to 7.8 pH. This means pH is alkaline. pH of semen is alkaline. Number 3, the third point which is very important is sperm concentration. Sperm concentration. Okay, one of the most important parameter is sperm concentration. Sperm concentration should be more than equal 15 million per ml. Okay, very important, 15 million per ml will be the sperm concentration. However, if you consider that it is 1.5 to 2 ml of semen, then sperm amount per ejaculate, sperm total amount per ejaculate will be 39 millions. 39 millions is the minimum sperms required per ejaculate. But what is important for us is we consider in ml per milliliter how much of sperm is the concentration. It is 15 million per ml. This is very important. Apart from that, only presence of sperm will not do. You have to see what is the motility of the sperm, whether sperms are able to move through the uterus and go upwards to the fallopian tube, ampulla of the fallopian tube, and it is able to fertilize. So for that, motility is required. So motility mein there are two parameters. One is total motility. The total motility should be always more than 40%, whereas progressive motility means forward motility. What is the forward motility? That should be always more than equal 32%. So 32%, at least 32% of the sperm should be progressively forward motile. So this is the motility. And the most important criteria which should be followed is what is the morphology of sperm. Morphology means how many concentration of the sperms have normal forms. That is, some sperm might be like this, some sperm might be like this, some sperm might be like this. There are different types of sperms which are present. But what is important is it should be normal form. The form should be normal of the sperms. Means it should have a head, a tail, mitochondria, everything should be present. So morphology, if you consider the morphology, then more than equal 4% of the sperm should have normal morphology. So it is very important. Although the number is very less, only 4%, 96% of the sperms can have other morphology, but at least 4% of the sperm should have normal morphology. Sometimes MCQ question comes, what is the most important parameter to be checked in sperm? It is not the sperm concentration nor the sperm motility. It is the sperm morphology which is the most important criteria to be seen in semen parameters. Apart from that, how many percent of the sperm are living? That is, what is the viability of the sperm? Viability of the sperm should be more than 58%. That is, 58% of the sperm should be living. Apart from that, coming to the viscosity. Viscosity. What do you mean by viscosity? Means what is the viscous nature or the viscosity or liquidity of this. So for viscosity we have a scale from 0 to 4, 0 being the most liquid one and 4 being the most viscous one. So it should be 0, 1 or 2. It should be 0, 1 or 2, means less than 3. If it is 3 or 4, then the semen is more viscous and it will not travel upwards. Then coming to leukocytes. What is the concentration of leukocytes which should be present? Leukocytes is indicative of infection. Infection in the genital tract, testicular infections or something like that will have leukocytes. So the leukocyte content should be less than 1 million per ml. Okay, 1 million in 1 ml of sperm. And what will be the round cells? Round cells means all other types of cells other than your sperm. So it can be leukocytes, it can be other kinds of cells, or it can be bacteria, it can be other types like epithelial cells. So the total content should be less than 5 million per ml will be the round cells. Okay, and less than 10% of the spermatozoa, less than 10% of the sperms should agglutinate. Okay, agglutinate means the sperms which are together, they are agglutinated or they are bound to one another, so they are actually not useful for fertilization. So basically 10%, less than 10% of the sperm should be agglutinated. So very important, I am revising once more. This is because this parameter will have one or the other question in your examination or MCQs based on that. So volume should be more than 1.5 ml. pH should be alkaline, that is 7.2 to 7.8. Sperm concentration should be more than 15 million per ml with a total concentration of at least 39 million per ejaculate. Okay, so 39 million per ejaculate. Okay, next comes the motility is more than 40%, but progressive motility is something which will be asked in examination. It is 32%. Morphology, 4% of it should be normal in morphology, 58% should be live, viscosity should be less than 3, that is 0, 1, 2. Leukocyte content as such will be less than 1 million per ml. If it is more, then it is suggestive of infections and you have to start antibiotics. If the round cell, total round cell should be less than 5 million per ml and less than 10% of the sperm should agglutinate. So what has come in exam is what is the most important parameter. I have already told sperm morphology. Sperm morphology is most important, followed by the second most important parameter is sperm motility, that is 32% will be progressively motile. Followed by that you have the sperm concentration which is 15 million per ml. Very important, if a male has less than 15 millions per ml of sperm, then this patient will be called oligozoospermia. Okay, less than 15 ml means 15 million means the count is less, concentration, then oligo means less, and zoospermia means sperm, so less number of sperms. Okay, now if the concentration is between 10 to 15, we know it is oligo, but if the male has count between 10 to 15, then our treatment will be IUI, that is intrauterine insemination. Just write it, because as we go forward you will come to know more detail. So intrauterine insemination, intrauterine insemination is to be done. If it is between 5 to 10 million, if the concentration is 5 to 10 million per ml, then we go for IVF, in vitro fertilization. And if concentration is less than 5 million per ml, then you have to go for ICSI. ICSI is intracytoplasmic sperm injection. Intracytoplasmic sperm injection. Okay, intracytoplasmic sperm injection has to be done. This is in vitro fertilization. Okay, So this is very important. Now coming to one more important thing, some of the terminologies which you should be knowing. First of all is when the sperm concentration is less than 15 million per ml, I have told. This is called oligozoospermia. Oligozoospermia means the sperm count is less. When the motility is less, that is less than 32%, progressively motile, then you say it is asthenozoospermia. Astheno means movement is less. Okay. And if the abnormal forms, if there is increase in abnormal forms of the sperm, that is normal form should be morphology, normal form should be at least 4%. But if the normal form is less than 4%, that is abnormal forms have increased, then it is called teratozoospermia. Now sometimes the count may be less, and at the same time there are abnormal forms, then it is called oligoteratozoospermia, or it can be asthenoteratozoospermia, oligoasthenozoospermia. Like this it can be, the terminologies can be confusing also. Apart from that, if there is zero, the sperm count is zero, then it is called azoospermia. Azoospermia means the sperm count is zero, but seminal fluid is there. Seminal fluid is coming because the seminal vesicles, the prostate and the bulbourethral glands are giving their secretion. But if there is no semen at all, कोई semen का volume ही नहीं आ रहा है, पूरा obstruction है, suppose the obstruction is at the level of outer urethra, then no semen is coming, then it is called aspermia. Difference between azoospermia and aspermia. Aspermia means there is no semen, and azoospermia means there is no sperm in the semen. Then if the WBC count, that is leukocytosis, is more than 1 million per ml, then it is called leukocytospermia. Okay. And if all the sperms are non-motile and non-viable, means motility is zero and viability is also zero, then it is a special term which is called necrozoospermia. Necrozoospermia means no motility is zero, as well as the viability is also zero. Then it is called necrozoospermia. Now remember, if a patient's report is azoospermia, उसका report में sperm count 0 आया है, then what you do is you take the semen specimen and you centrifuge it. Normally we do not centrifuge, but when it is azoospermia or oligozoospermia, we centrifuge it to 3000 G for 15 minutes. 3000 times the gravity, and for 15 minutes you centrifuge. And then in the concentrated semen, then we get a concentrated semen. In that we again put under the microscope and check what is the concentration. If still you are getting 0 or azoospermia, then you ask the patient to come in 1 to 2 days, and you take a next sample, a second sample, and again check. If the second sample is again giving 0, then you label the patient as azoospermia, because labeling a patient as azoospermia is very psychologically impairing for him, because he will have to undergo treatment for azoospermia. He has 0 sperms. So in Indian setup or any other country even, labeling a patient as azoospermia is very psychologically disheartening for him. So you have to generally repeat the specimen in centrifuge specimen, as well as you have to do it a second reading, then only you can tell a patient as azoospermia. Now the question comes, let us study how to manage a patient with azoospermia. In your clinical setup, when you are in a hospital, you will find patients coming to you with report of azoospermia. Now what can be the cause of azoospermia? If you think in medical terminology, what will happen? First, the hypothalamus is secreting GnRH, and GnRH is coming to the anterior pituitary. From anterior pituitary, we all know FSH and LH are being secreted. FSH will go and it will secrete, it will help the Sertoli cells. Other name is sustentacular cells also, remember. Sertoli cells, and Sertoli cells will produce the sperms. So spermatogenesis will occur. Whereas LH will stimulate the Leydig cells and then testosterone will be produced. This all we know. Now what happens is that there can be, now this Sertoli cells and Leydig cells, this testosterone and sperms all are produced in the testis. So this is at the level of the testis. Okay. Now this sperm again comes out and it goes to the outer wall through the urethra. Now my patient's problem can be at the level of this, that is, it can be pre-testicular azoospermia. It can be, the cause can be here, so it can be a testicular form of azoospermia, or it can be an outflow tract obstruction, so it can be a post-testicular azoospermia. Okay, so every aspect will have different causes and difference how to we generally manage it. So let us consider first the pretesticular form, the pretesticular azoospermia. So in pretesticular form, the defect is usually at the level of your anterior pituitary or in the form of hypothalamus. So basically what happens is it will be like hypogonadotrophic hypogonadism. So like the patient will have FSH LH will be low, at the same time patient's testosterone will also be low. So when FSH LH is low and testosterone is also low, then the cause is pretesticular. So pretesticular causes, what can it be there? It can be endocrine disorders. So patients can have like hyperprolactinemia, thyroid dysfunction, gonadotrophin deficiency. Okay, all these things can be there. Or it can be because of psychosexual problems, sexual issues related to somebody. Then it can be because of stress, it can be because of some drugs if patient is taking like antihypertensives, or it can be because of Klinefelter syndrome. Okay, like all the syndromic ones, Klinefelter syndrome like XXY and all these things. Like we have also studied in our previous lectures that Kallmann syndrome is defect in the hypothalamus, whereby there is midline structures are defective, so there is anosmia also. So all these things will come in your pretesticular causes. Coming to testicular cause, when there is testicular cause, what happens is FSH and LH will be high. बिकॉज आपका नेगेटिव फीडबैक से क्या होगा, व्हेन आपके टेस्टिकल्स काम नहीं कर रहा है तो ऊपर वाले हार्मोन सारे बढ़ जाएंगे, तो FSH and LH will be raised, however testosterone will be low, so it is hypergonadotrophic hypogonadism. Hypo. What can be the causes? Anything related to the testicles, like it can be orchitis, that is infections of the testis. It can be like mumps can also lead to mumps. Orchitis can be one of the causes. Then it can be because of cryptorchidism means a patient who has undescended testis. So these all things, the testicular environment will be heated, so it will not be forming the sperms. Then it can be because of immotile cilia syndrome, because of the cilia are immotile, so basically the sperms are not being formed properly. Even if it is formed, they are not transported. So it can be because of Carter-Jenner syndrome. Carter-Jenner syndrome is a syndrome where there is immotile cilia, or the cilia are not formed properly. So these are the causes of testicular causes. Then coming to post-testicular cause. Post-testicular cause can be mostly any blockage in the outflow tract. So it can be, the blockages can be in the form of, say, there can be absence of vas deferens. So congenital absence of vas deferens can be there. There can be Carter-Jenner syndrome, whereby there can be problem in the vas deferens. Motility of the vas deferens are not there. There can be Young's syndrome. Young's syndrome is a syndrome which is acquired, and there is immotility of the cilia, so that it is not exporting. Then it can be following a vasectomy also, which is iatrogenic. After iatrogenic, okay, patient can have azoospermia, so it can be because of that. Or a most important cause can be retrograde ejaculation. Many of the patients will have retrograde ejaculation, whereby their semen is not coming out of the urethra, but it is going back into the urinary bladder. There the semen is being destroyed, the sperms are being destroyed because of the acidity of the urine. So these patients will have normal FSH-LH, their normal FSH-LH will be there, and they will have normal testosterone. So hormonal level will be normal. It is the block which is leading to azoospermia. Now the next question which comes to our mind is, what is the level of the block? Because post-testicular cause of azoospermia is the most common cause of azoospermia. Means blockage of the outflow tract, which is also called as obstructive azoospermia. This is also called obstructive azoospermia. Obstructive azoospermia is more common than non-obstructive azoospermia. So most of the patients who will come to you will have FSH and LH normal, testosterone will be normal, but still they will have azoospermia. So it is somewhere there is blockage. So for knowing the level of obstruction, the next test which we get done is seminal fructose. The seminal fructose test is done. So it means that we will see in the semen specimen whether fructose is present or not. What we have earlier spoken about is, if fructose is present, it means fructose is produced by the seminal vesicles. So if the blockage is before the seminal vesicle, then fructose will be present, because fructose will be secreted and it will come out. But if the blockage, or if the problem is either absence of seminal vesicles, or the blockage is below the level of, anywhere below the level of your seminal vesicles, then fructose will be absent. So this test is done and it is really very helpful. So seminal fructose can be present or absent. If the seminal fructose is present, then the blockage is before seminal vesicles. And if it is absent, then it can be two problems. One is seminal vesicle is absent, or the blockage is after seminal vesicle. Okay, then seminal fructose will be absent. So if so this is the thing. So if the blockage is before seminal vesicle, then we will generally get an ultrasound of scrotum done. It can help us to know whether there is any tumor or something like that which is obstructing the vas deferens. If seminal vesicle is absent, so seminal vesicle absent is generally seen in a condition which is called cystic fibrosis. Very, very important. Cystic fibrosis mein seminal vesicles are congenitally absent. So if cystic fibrosis is suspected, then get CFTR gene mutation done. CFTR is cystic fibrosis transreceptor gene. Cystic fibrosis transreceptor gene. This has to be tested. If this is abnormal, then cystic fibrosis is diagnosed. And if the blockage is after the level of this thing, then get a transrectal ultrasound done. Transrectal ultrasound, because scrotal ultrasound will not help in telling, because now this problem is at the level of, either at the level of your prostate gland or somewhere in the urethra. So it will be diagnosed in a rectal ultrasound rather than a scrotal ultrasound. So this is how we generally go about. Now what will happen if you have an obstructive azoospermia? If your patient has obstructive azoospermia, means the testis is producing the sperms properly, but it is not coming out. In this case, what you do is, you can directly take the sperms by introducing a needle into the testis. So a needle is introduced into the testis and all the sperms are taken directly, and then in vitro fertilization, that is in the outside environment we will go for fertilization. So what is this process called? This process is called TESA. TESA, what is TESA? Testicular sperm aspiration. Testicular sperm aspiration. Then you have other techniques also, like your TESE. TESE is testicular sperm extraction. Okay, one is aspiration, that is put a needle and then aspirate it, मतलब negative pressure बना के बस खींचना है. This is called TESA, testicular sperm aspiration. Then sometimes अगर aspiration से negative pressure से नहीं आ रहा है, what we do is we introduce a biopsy type of needle and then we get direct biopsy from the testicles. This is called testicular sperm extraction, TESE. Then you have MESA. MESA is microsurgical epididymal sperm aspiration. Means we can have, if the epididymis is full of your sperms, you can have introduce the needle into the epididymis and यहाँ से भी extraction कर सकते हो. तो it will be microsurgical epididymal sperm aspiration, or it can be PESA. PESA is परक्यूटेनियस एपिडिडाइमल स्पर्म एस्पिरेशन. मतलब यहाँ का जो स्क्रोटल स्किन है इसमें थोड़ा सा इंसिजन दे दिया एंड देन गो इनसाइड एंड देन एस्पिरेट फ्रॉम द, so it is percutaneous. So from the cutaneous area you go and then epididymal sperm aspiration. So these all techniques can be done if patient is having obstructive azoospermia. But if it is non-obstructive azoospermia and there is problem in the hormones or the LHFSH, then your treatment will be pulsatile GnRH therapy. That is, you are giving pulsatile gonadotrophin releasing hormone therapy. This hormonal therapy will help in production of testosterone and also in spermatogenesis, because problem is above, that is hypo. So the best prognosis in azoospermia, best prognosis will be with obstructive azoospermia, because their hormone levels are all right. It is only the obstruction. So you have to just bypass the obstruction and extract the sperms. The poorest prognosis is hypo. मीन्स प्रॉब्लम ऊपर से है, तो ऊपर से सारा ट्रीट करते हुए आपको सारे हॉर्मोन्स दे के लेके आना पड़ेगा. ओके, सो नॉन ऑब्स्ट्रक्टिव एजोस्पर्मिया इज एसोसिएटेड विथ पुअर प्रोग्नोसिस. ओके, so this is all about how we generally approach a male of infertility. Okay, now one more thing which I want to add is that sometimes you are asked in examination, what is ENDS test? ENDTZ. What is ENDS test? ENDS test is helps in differentiating between leukocytes versus other cells in semen. ओके, सो सीमेन में समटाइम्स अदर सेल्स, जैसे राउंड सेल्स हो गया, उसमें हमने बोला है कि 5 मिलियन पर ml से उससे कम होना चाहिए, उसमें से 1 मिलियन पर ml से कम होना चाहिए ल्यूकोसाइट्स. सो हाउ डू यू डिफ्रेंशिएट वेदर द सेल्स आर ल्यूकोसाइट्स और सम अदर सेल्स? विद द हेल्प ऑफ some immunoperoxidase staining test. We do some staining test which helps in differentiating the leukocytes. Leukocytes will take up the, WBCs will take up the stain and other cells will not take up the stain. This test is called the ENDS test. There have been questions in your NEET exam, so I wanted to revise this once more. ENDS test, you might have studied in pathology, but we tend to forget. That is why I have told it in details. Okay, so basically what I was speaking was that I had already told कि normally 15 million से ज़्यादा होना चाहिए sperms, but जब 10 to 15 million होता है तब हम क्या करते हैं? IUI. Now what is IUI? IUI is intrauterine insemination. So basically this is the uterus and this is the outflow tract. Okay, so what we will do is we will take semen from the patient will give the semen specimen. Okay, normally he will give the semen specimen. We will process the semen specimen and we will centrifuge it. After centrifuging, the sperms will be concentrated. Once it is concentrated, we will take a pipette and in the pipette we will load the semen and then we will introduce the pipette into the uterine cavity and we will push the sperms into the uterine cavity. This is called intrauterine insemination. This is called IUI. सो बेसिकली व्हाट वी आर डूइंग इज उनका काउंट थोड़ा सा ही कम है, ज़्यादा नहीं, कम है, तो 10 to 15 के बीच है, तो हम क्या करेंगे उसको कॉन्सेंट्रेट करके स्पर्म को यूट्रस के अंदर डाल देते हैं. रेस्ट ऑफ इट द स्पर्म्स विल देमसेल्व्स ट्रैवल टुवर्ड्स द एम्पुला एंड गेट फर्टिलाइज. सो दिस इज आईयूआई. आईयूआई बहुत सस्ता होता है बिकॉज इसमें कुछ ज़्यादा करना नहीं होता है. बट व्हेन द स्पर्म काउंट इज लेस देन 10, दैट इज 5 to 10, then we go for in vitro fertilization. In vitro fertilization we take semen or sperm from the father and then we take ovum pickup. Ovum pickup is done when the patient ovulates. तो ओवरी से डायरेक्ट नीडल डाल के वी विल गेट द ओवम. सो ओवम एंड स्पर्म वी विल फर्टिलाइज इन अ पेट्री डिश आउटसाइड. सो इट इज इन विट्रो फर्टिलाइजेशन. And then the zygote will be formed, and then the morula and the blastocyst. Then the blastocyst will be implanted into the endometrial cavity externally. It is called embryo transfer. Embryo transfer बोलते हैं, ET बोलते हैं, ठीक है. तो एम्ब्रियो ट्रांसफर करते हैं एंड देन वी कंसीव. सो बेसिकली प्रैक्टिकली स्पीकिंग यू नीड ओनली वेरी फ्यू स्पर्म्स एंड ओवम. ओनली वन ova is enough. One ovum and a few sperms are required for fertilization. But when the count is very less, that is 5 million से भी कम है, then we go for ICSI, intracytoplasmic sperm injection. इसमें क्या होता है, एक ओवम ले लेते हैं एंड एक स्पर्म ले लेते हैं. उसी एक स्पर्म को हम इंजेक्ट कर देते हैं into the cytoplasm of the ovum. So it is called intracytoplasmic sperm injection. So basically you need one ovum and one sperm for ICSI. So this is the most advanced form of fertility treatment, but it is very costly. So all patients cannot undergo this. Now for processing of sperms, whenever you do IUI or IVF or ICSI, your sperm should be concentrated and should be processed. So for processing of sperms, basically you have swim up technique, okay. Then you have swim down technique, and the best one is density gradient technique. Density gradient centrifugation, okay, centrifugation technique, okay. So density gradient centrifugation technique. So what actually happens is swim up technique में क्या करते हैं, you take the semen specimen and you put it in a container which will contain a solution, okay. You need not to go to the details of the solution, ये तुम लोगों के लेवल का नहीं है. So what you do is by density the sperms will try to swim up and they will come to the upper layer and then they will get collected. From here you just scoop out the concentrated sperm. So this is called swim up technique. Swim up technique is least costly, ठीक है, मतलब ये सबसे cheapest है, okay. This is the cheapest and so most commonly done. It is the most commonly done is swim up technique. Remember this MCQ question. Swim down technique is you take the semen specimen take a solution and then put the semen specimen above, okay. This solution will be lighter. So what the sperms which are viable, they will be heavy and they will come down and you collect it from below. So this is swim down technique. And then you have density gradient whereby you centrifuge and then the viable sperms will be separated from the non-viable sperms. So these are the techniques which are generally done for these patients women who have cervical factor infertility. Very important, okay. Next question, cervical factor infertility. Cervical factor infertility का मतलब क्या है कि this is the uterus and this is the cervix and this is the vagina. So some women have in their cervix they have anti-sperm antibody. इसका मतलब क्या है कि जब भी वो कोइटस करते हैं and the sperms are introduced into the vagina and the sperms tend to enter through the cervix into the uterine canal, these sperms are damaged. because these women have anti-sperm antibody in their cervical fluid. So what basically is the cause of their infertility is an outflow tract obstruction. It is a physiological obstruction, anatomically कोई obstruction नहीं है, but the sperms are being damaged by the anti-sperm antibody. So treatment of cervical factor infertility is technically IUI, intrauterine insemination. So when you do intrauterine insemination, you introduce your pipette and you introduce the sperms in the uterine cavity. So basically sperms को अब यहाँ से बस ट्यूब्स के थ्रू जाना होता है. They have bypassed the anti-sperm antibody of the cervical fluid. So IUI is the treatment of choice for cervical factor infertility. So this is how we generally manage patients. So basically in infertility, what you need to remember is first try to find out the cause of infertility, because सारे causes के लिए अलग अलग treatment होता है. So when you find out the cause of infertility, 70 to 80% of your work is done, because now you will be goal directed treating the patient. So today we have discussed in this class about male infertility. What are the various causes of male infertility, how pre-testicular, testicular and post-testicular infertility are really different. Post-testicular or obstructive cause of azoospermia is the most common. WHO semen parameters are very important. You get MCQ every time on this, and depending upon your fructose content you can know what is the level of the obstruction and accordingly treat. So thank you for this class, and in next class we'll be talking about female cause of infertility, and then we will summarize as a whole how you approach the patient and how you treat it. Thank you for attending Medi Mantra, and I hope you have a happy learning class.